everybody. I trust you can see and hear us, hear us both as we're talking to you. As John said, we're in Brisbane at the moment, and we are really happy to be here and looking forward to presenting a little bit about our journey. Now, if you have a think about this, you will know somebody who's really going through a health issue at the moment, be it a partner or a sibling or a parent or a friend or somebody who's just having a health struggle. We know that our story isn't unique. We know that it's something that everybody goes through, or if you haven't been through it, you will go through it, or you will know somebody who's going through a health challenge. But this is a story that really depicts a little bit more about Ashley's journey through his healthcare experience, and it is a story that's very close to our hearts. I have spent my whole life working in digital health, and through Ashley's story, it's really become clear where digital capabilities can change the health experience, both for us and for your loved ones and for those people that are caring for you.
Sari and I have been very fortunate and have had a very, very good life. We have worked and travelled all over the world, and including Europe, Africa, Asia and the Americas, spending so much time seeing the world and enjoying work. Like Sari, I have also worked in the health IT industry and also in IT journalism and investment trading. I'm Ashley McKinnon, and I've been a diabetic type 1 since the age of 12. After more than a few ups and downs in my teenage and early adult years, I've been relatively healthy for the past 20 years.
It was in December when life really changed for us. Ashley had been sick, and not that sick, but just quite unwell for a couple of days. But we knew when we went into an A&E department here in Brisbane in Australia, he knew that something was very, very wrong. And I have to say, in December, when this discovery was made, he had really only been ill, like seriously ill, for a good couple of days. When we walked into the A&E department, the physician there was really wondering why we were there. They asked us lots of questions about, had we been to other physicians beforehand, because Ashley didn't present as the normal sick person would. But after the initial blood tests, the hive of activity started. And it was pretty clear that Ashley was in a very life-threatening condition, and he pretty quickly was determined that he was really, really ill. He was surrounded by an A&E physician, by the nephrologist, by a cardiologist, by endocrinologists, by intensivists, by nurses and by pharmacists. And the list actually goes on. Even some of the specialists that we were talking to at the time, or who came in to see him at the time, were mentioning the excitement that Ashley had created in the ward because of his condition, his unusual presentation where he didn't look that sick, but then his blood tests and scans and x-rays all showed how ill he actually was. I distinctly remember doctors asking us for recent blood results from pathology tests that Ashley had taken through his regular and routine HbA1cs. Now, we know these were taken just a few months beforehand as part of his regular testing, but nobody could locate the results in a hurry. So it ended up being just easier, unfortunately, to redo the baselines and retake the bloods and start from scratch. After the rounds of bloods and different tests and x-rays, it was confirmed Ashley was in acute renal failure. He was desperately ill, and he was admitted to ICU just a few hours later. I have to say, the one-on-one care that Ashley received both in A&E and in ICU, in the intensive care unit, they were fantastic. The doctors, the people caring for him, the providers were just above and beyond. But when it came with these rounds of activities, lots of tests, waiting for results. And generally, I've got to say, the results weren't really all that positive or all that good. They weren't things that we really wanted to hear. The care team was growing hourly. There were more nurses, there were more pharmacists, more dietitians, there were dialysis team members. It was really pretty endless. Interestingly, everyone who came asked the same questions over and over again. While information was clearly recorded and it was written down and it was entered in very complex clinical information systems and electronic medical record systems, where was it and why couldn't it easily be accessed by those people who are really caring for Ashley? While Ashley was in ICU, it was confirmed that he needed a renal and a pancreatic transplant. And through all of this, one thing was really, really clear. Data was everywhere. It became really obvious really quickly that it wasn't a lack of very complex systems on the ward or in the hospital or purpose-specific solutions, at least at the hospital level. But systems weren't connected and the information just wasn't really being shared across all of the care team, which was pretty extensive by this stage. So getting a historical single view of Ashley's clinical information in a way that could be shared across the care teams, that was really the challenge. We aren't even talking about Ashley's access to his own personal medical information. And Ashley and I both have worked in this industry for a long time, so we really do understand the need for privacy and for cybersecurity. But when you're that sick and that unwell, you do want to know what's happened to you. You want access to your data and you want to be able to navigate through the different healthcare experiences that you've got. If you think about what happens to a patient in the first 6 months of their care, and this is talking from Ashley's experience, in the first 6 months of his care, he had over 110 specialist consultants, over 4 operations, 16 images were taken, well over 160 pathology tests, and nearly 2,500 medication doses. Now, this didn't actually even include the dialysis treatments that he had in hospital and then at home. You think of the data that would have been generated. It's just wow. There's a huge amount of data in all of that investigation that would have happened in those early months of his care. After a few months of hospital trips and in-house, in-hospital dialysis treatment, it was decided that Ashley would be a prime candidate for hospital in the home. And we were able to have the dialysis treatment at home, which was fantastic. You know, it's such a gift here in Australia to be able to have hospital in the home and dialysis treatment and regimes that are delivered in the home. Now, not every country provides this. We're fully aware of that. And so I think we are blessed in Australia to have this type of service. And not every patient is able to manage the renal dialysis themselves and be able to manage their machines and monitor themselves. And sticking the needles in, you know, that can be really, really difficult. So one of the things that really surprised me, though, as a result of all of this information that was collected and the complex systems that we had in our hospital in the home, was that the dialysis machines that we had supporting Ashley's and giving him life, there was a huge amount of monitoring that was happening, but these systems weren't actually connected to anything. The data wasn't really going anywhere, and the data wasn't really collected for any particular purpose. And the monitoring that Ashley did on a daily basis, yes, he filled out his temperature, his blood pressures, but nobody really looked at them. He religiously filled out all of these forms every hour on the hour, and this was over multiple years. And every second day of, 4 hours of dialysis treatment, nobody really looked at his OBS. And he took them to specialist appointments to medical appointments, but they weren't really looked at. So Ashley's care was very complex. We know that. It involved lots of coordination and involved a multidisciplinary care team, including primary care and a range of allied health and supporting services. He was a public and he was a private patient, and we would require transplant teams in multiple states across Queensland and across New South Wales. And there were multiple follow-ups, and there was a lot of treatment and a lot of multidisciplinary care. And we know he had large numbers of healthcare providers who were focusing on different areas of his healthcare, but the communication process across all of the different providers that he had, it was pretty poor, and it was pretty difficult. You can see on the screen in front of you there a view of the number of different healthcare providers that Ashley had looking after him through this period over a couple of years when he was waiting for his dual organ transplant. There were lots of different care teams and across lots of different states. Yes, we had a My Health record, which is managed by the Australian Digital Health Agency here in Australia. But one of the things that Ashley really found through the course of his care was that his healthcare providers, and yes, he was a private patient, probably even more so than receiving public care, they weren't that interested in accessing the My Health record. They certainly weren't uploading information into the My Health record, so it never really had a complete picture of what was happening through Ashley's journey, and it wasn't something that really could be shared across all of the healthcare providers, other than them all getting individual access. And I have to say, the My Health record itself, it isn't really that easy to navigate for a healthcare consumer or the healthcare providers. Now, a lot of these challenges are known to the Digital Health Agency and to the organisation, and there's a modernisation program in place to address a lot of these. But one thing we found through Ashley's healthcare was that while he was getting a lot of treatment, the only real point of coordination and navigation of his care was Ashley himself, and that was the patient. And we were really fortunate in the fact that Ashley could be proactive in his healthcare. And it really breaks our hearts when we think about the people who might fall through the system and fall through the cracks. And there's lots of different reasons why that might happen. Some just may not be capable. Some might be older. Some might have cultural or language barriers. Some may just not know what they don't know through this healthcare process, especially when it's a really complicated condition. I'm going to hand over to Ashley now and he'll talk a little bit about some of the challenges that he really faced as a patient, as a consumer, getting complex treatment in this very complex healthcare system.
Thank you. I'm going to give you a few examples, slightly different to what's shown on the screen. And then SMSs, to qualify to have a dual transplant, I had to go through many different scans and tests to make sure I was suitable. These included blood tests, circulation scans, heart stress tests, and many more. This was usually coordinated by doctors and medical professionals by sending out SMSs with the time and location of procedures. This all worked pretty well, except for sometimes these SMSs would come from a number that would show as either private number or even worse, suspected spam. As you simply can't reply to a private number, there's no way of telling who it was from. So I'd have to do a random ring around of multiple people and try to work out who it was from and exactly what it was for. Example number 2, medications. After the dual transplant, which was done down at Sydney, I had to go back down a year later for the yearly review. And I met with the doctors and nurses who'd looked after me when I'd had the operation. I had multiple tests and scans done, and I would say at least 15 or so over a 4-day period. Later, when I got back to Brisbane and went to see my renal specialist about 3 weeks later, her first question to me was, has any of your medications changed, as I haven't received any info from Sydney yet? I also checked up on my health record to see if it had been updated, but none of my results were there yet, and only one of the 4 scans that I had did actually finally make it up there. And here's a recent example of something that very, very much frustrates me. As someone who is regularly going into hospitals to have procedures and tests done, it can get very frustrating how I have to repeat my information over and over. Recently, I checked into a hospital for a procedure and had to repeat my personal details upwards of 7 times before the actual procedure. Once at admission, then again at the initial review, then I was taken into the waiting area, which again, I had to give my details again. And then when I was taken into another room to change into a gown for the procedure and have my belongings put into securely away, I had to give my personal details again. And then when I was being wheeled, before I was wheeled towards the theatre, I had to give my personal details again. While I was waiting outside the theatre, I had to give my details again. And then when I was finally wheeled into the theatre, you can pretty much guess what they're going to do. They're going to ask me for my personal details again. I don't mind giving my name and date of birth, but personal details are a bit more than that. It's usually upwards of a 5-minute conversation giving up all your details. What would be nice is if I didn't have to constantly repeat all this information over and over. And now the day we'd been waiting for had finally arrived. We were heading to Westmead Hospital and travelling from Brisbane to Sydney interstate. The call came at 5 a.m. in the morning and we were on a plane 5 hours later at 10 a.m, having many rounds of tests and preparation, a final round of dialysis, and were visited by lots of different surgical specialists and nurses. And then I was in theatre by 7 p.m. So it was all go, go, go. And mind you, this all happened during the height of the pandemic lockdowns here in Australia. But again, that's another story for a different time. It was a very big day with a large transplant and surgical team involved. After the surgery, we stayed in Sydney for about 6 weeks or so of post-op care. If you were to ask me what I wanted as a patient receiving care, it's pretty simple, really. I want access to my clinical information, and I understand not all patients want that, but I would love to see it all in one place so that everyone caring for me can see it too, including what has happened to me and what is planned for the future. Imagine if communication across care teams was easier, if those looking for me had access to all my clinical information and history, how much better that would be for me and for those caring for me.
Interestingly, we remember when we were finally discharged from the Westmead Hospital, we saw this pharmacist coming towards us, and I had a joke with Ashley and said, oh, imagine, having to take that backpack, and imagine if it was full of medications and having to take that through the airport. Well, the joke really was on me because that pharmacist was delivering Ashley's discharge medications in that backpack, and it was full. And it was full of medications, not only his post-op medications, but also anti-drug medications. And sadly, it was only about a month's worth. Such a shame that none of those details of all those medications were available electronically. Yes, they gave us a nice piece of paper, but I'm not sure how useful that would have been for the rest of the broader multidisciplinary care team.
And when we got back to, and you'll never guess what happened when we got back to Queensland. That's a 2-page document that they gave me, a little pamphlet with all my medications on it, didn't actually adhere to the Queensland standard for medications. So I had to wait. When I saw my renal doctor, I had to wait while that was transcribed over to the Queensland friendly format, which is fine, but it also meant whoever was waiting in the waiting room with me, they were pushed back 45 minutes as well. Imagine how much easier it would have been if medication data was made available electronically and in a shared digital format?
I've worked across health informatics for 30 years and in digital health for 30 years, and I really do love it. And it's this story, it's Ashley's story, that really makes us realise this is why we do what we do, and this is why we keep at it after all of these years. I've always worked in interoperability and across this space, and it wasn't until Ashley got seriously ill that I really developed a different perspective on the impact of the everyday challenges that a patient like Ashley has trying to navigate through healthcare and through our system. It gave me such a deeper lived experience of what was really needed. And we can make it easier. The potential of digital is huge. It largely is about sharing and communicating, not only to improve the experience of healthcare providers, care providers, but the patient as well, for them to be able to navigate through their healthcare system. It can get complicated, but it doesn't have to. It's all about user-friendly access, really consistent, standards-based data that you can enter once and reuse many times, trusting that information, and then being able to share that information. So 2 years on, the future, it's really bright. It's really promising. It looks good for us. The ongoing monitoring, that's still going to happen. It'll happen for the rest of our lives, and I should say for the rest of Ashley's life. But please, for those that you care, for those that you love and those that you are looking after, let's think about how to sort this thing out. Let's really think about how we can make communication, sharing of patient information, shared records more available, more accessible, and really up to date and current to improve the quality of care for all of us. So that's really Ashley's story. So thank you so much for letting us share just such a small part of it with you. It's a much longer story, but we won't bore you with all of those details. So I'll hand it back to John. Thank you.
Thank you.